Welcome to the Speaking of Women's Health podcast. I am your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health, and I also am the Director of the Specialized Women's Health Fellowship. And it's so exciting for me to invite one of our esteemed graduates on today's program, Dr. Tiffany Cochran. And Dr. Cochran, you've heard me talk about her in former podcasts because I have podcasted a lot of her great information that she's done for Speaking of Women's Health on topics from menopause to dry eye syndrome, which is a big problem for women, rosacea. And Dr. Cochran is an internist and a women's health specialist. And she's at Beaufort Jasper Hampton Comprehensive Health Services. And she sees patients at the Port Royal Medical Center in Port Royal, South Carolina. And Dr. Cochran graduated from our Specialized Women's Health Fellowship recently, a year ago at the Cleveland Clinic. And she first got her Bachelor of Science from Valdosta State University and her Doctorate of Medicine from Morehouse School of Medicine. And in addition, she's so well educated, Dr. Cochran also has an MA in Healthcare Administration. And as I've mentioned before, I hope at some point in time we can get her back to come to the Cleveland Clinic. She's got family and friends in the area, and I hope to see you in October, Dr.
Yes.
Cochran. Welcome.
Thank you for that introduction.
And just before we start this podcast, which we're going to talk about women's health and hormones and women with blood clots. And blood clots have kind of been on the rise and are certainly a life-threatening condition in anyone and does complicate lots of women's health issues. And Dr. Cochran authored an excellent chapter in this Mayo Clinic book, Taking Care of Your Body. It was a book by women physicians for women patients, and she did one of the chapters on everything you want to know about blood clots. So that's what we're going to talk about. But before we get in to this, today is one of the first days of the new academic year with our new fellows, and I want to bring in our fellowship coordinator, Chad. You wanted to say hi.
Dr. Cochran, we miss you, we love you, and we're very proud of you.
And you can catch one of my podcasts with Chad about our fellowship. And then I want to welcome the two new fellows that we have that are starting for the next 2 years. Dr. Madeline Cone, she said is an ice cream cone, and Dr. Rachel Novick. And they're both board-certified family medicine doctors who will be spending 2 years getting educated on all things specialized women's health, menopause, hormone therapy, care of breast cancer survivors, osteoporosis, sexual dysfunction, all these important topics that can affect women through their life cycle. So, Dr. Cochran, tell me, how did you get interested in blood clotting disorders in women and how women's health issues influence those conditions?
Well, we usually are prescribing hormonal therapy to women. And one of the complications behind taking hormonal therapy of any form is the possibility of clot formation. And that's just because of how estrogen works in the body. It stimulates the liver to make those factors that end up causing the blood to be stickier, which is its role. So I wanted to be able to take care of these women and to give them the benefits of the hormone therapy for their longevity of life and all of those great benefits that Dr. Thacker always mentions in each one of her podcasts without causing more harm to my patients. Because as doctors, we always try to minimize the harm while we help our patients. So I wanted to make sure I knew everything or was well versed in all of the complications, and the most common is blood clots.
And what are some of the conditions that people should know about, either in their family history or personal history, that puts them at increased risk for getting blood clots?
So the first thing that you should know from your family history is there a genetic disposition or a genetic risk for you to form clots? there are family members who have different factor deficiencies or different mutations. To name a few is factor V Leiden, protein S, protein C. Another common one that doesn't really turn a lot of eyes of vascular medicine doctors is the MTHFR, which is the methylene tetrahydrofolate reductase mutation, which alone by itself is not much of a concern. Usually it's the homocysteine level with that gives the vascular medicine their red flags come up, as to say, like, oh, ding ding, we need to do something about that if we're giving a person hormones. But that's one thing you need to think about. Is there a genetic increased risk for you to have clots? Second, has to do with your lifestyle, because that kind of is inherited from generation to generation. So making sure that you're mobile, making sure that there's no the nutrition. You want to make sure that you're not eating too much processed foods or fast foods that can lead to the chances for diabetes and hypertension, hypercholesterolemia, which are all in itself another family risk factor, because if you have those genes that increase your chances of developing diabetes and cholesterol, that can also lead to increased risk for clots.
Mm-hmm. And so being physically active, getting a healthy weight, which we've talked about a lot of those on former podcasts, having a healthy, nutrient-rich diet. In fact, the Superfoods podcast, I think, was our most listened to podcast, staying hydrated. And then what about certain medications? What are medications that might increase someone's risk if they're predisposed to having blood clots?
So some of the medications for sure has to do with hormones. So that could be from birth control pills to menopausal hormonal therapy. Another risk factor, another medication that can increase your risk for clots is tamoxifen, which is a common used medication for women who had breast cancer or on prophylactic therapy for breast cancer. Then there's a specific type of medication called a selective estrogen receptor agonist. Those can kind of act similar to estrogen and increase your risk for clots. And then those are about the main ones that most doctors would be concerned about.
Mm-hmm. And in your chapter, I'm looking at your chapter right now, you had added spemifene, which is one of the only oral agents that we use that's not a hormone that actually helps with vaginal dryness and genitourinary atrophy syndrome of menopause. Mm-hmm. So when you say oral contraceptives or the pill, do the contraceptive patches and the contraceptive vaginal rings have the same risk of blood clot?
Based on research, so after the WHI clinical trial published their results that had mentioned about higher risk of clots with menopausal hormonal therapy, there was other studies that came out that looked at clot risk and hormonal therapy. And what they found is you have more chance or higher risk for clots with the oral medications for hormonal therapy than the transdermal options, just because of physiology. So the oral hormonal therapies have to be processed through the stomach, then eventually goes through to the liver, and that leads to an increased risk for factors that leads to the blood being stickier compared to the transdermal options, whether it be a patch or a cream or a spray. Those don't go through the liver, and so it just stays in your blood, so there's a less risk of those clot factors being produced.
Mm-hmm. And so certainly for menopausal hormones, physiologic estrogen replacement through the skin as opposed to through the stomach and liver that makes the clotting enzymes is associated with less of a risk of clot. But if it's high-dose synthetic contraceptive hormones with estrogen, then that still is an increased clot risk because that's pharmacologic, not natural and physiologic. So in a woman who needs contraceptive doses of hormones, even if she wears it by patch or by vaginal ring, we if she was high risk, probably would pick a different contraceptive like
Yes.
an IUD or a progestin-only option, or barrier methods, or in that regard. So, do you prescribe hormone therapy, menopausal, to women who've had blood
I
clots?
have both in my fellowship as well as during my time here in the clinic as an attending. I just go over
Hmm.
the reasons why I am choosing to go with menopausal hormonal therapy because that risk is not 0%, but it is a way that we can give women who are suffering hormonal therapy while minimizing their risk for the clot formation. So I just go over that mechanics of
And then do you only use transdermal estrogen in those women, or do you ever use oral hormones if they're already on an anticoagulant?
So my first aim is to try to see if I can get her control on the patch. But if for some reason she's not able to absorb or get enough in her blood system, I would discuss the possibility of doing an oral estrogen pill at the lowest dose that I can see would help her with her symptoms. And then I would just advise about the studies that show it increased risk. But again, that estrogen dose for menopausal hormonal therapy routes are usually lower than birth control estrogen. So that risk would still be a little bit lower than for clots for menopausal hormonal therapy than for hormonal contraceptive medication.
Hmm. And do you want to talk about how clots are sometimes treated, whether it's low molecular weight heparin or warfarin, also known as Coumadin, previously known as rat poison, and some of the other newer direct oral anticoagulants?
Yes. So nowadays, if you come to me or any primary care provider and you've had a deep vein thrombosis or a clot in the legs or the lungs, we usually are going to give you a medication, the lower molecular weight heparin, first, depending on if you're in the hospital setting, outpatient setting. Most of the time when you have a clot, you're going to be first in a hospital setting, so they're going to start off with a heparin injectable or drip that they give you in the hospital. And then once they have figured out if they need to do anything more serious for you, they'll switch you to an oral medication. And now giving convenience of not having to get your blood drawn on a regular basis and checking a particular test to make sure the medication is at a good level to work for you, they choose newer agents called Xarelto, or I never can say this one, Rivaroxaban. That's Xarelto, or Eliquis.
Xarelto.
Or Eliquis,
Hmm.
which is apixaban. Those are the two most common, even though there's some other direct oral anticoagulants, and these are the newer agents. If you have a special condition, such as antiphospholipid antibody, or if you have some type of mechanical valve in the body, then your doctor may choose an older medication called Coumadin or warfarin, and that one is more trickier because you have to eat a very specific diet, and you have to go get your labs drawn, and they have to look at this blood test to make sure it's at a therapeutic level. So most of the treatments is with the newer agents, unless you have some kidney function, then they'll do the Lovenox, which is that lower molecular weight heparin that most people are familiar with when you go in a hospital and get those injections in the stomach while you're in the hospital.
And low molecular weight heparin's used a lot in pregnancy for women at higher risk of clot,
Yes,
isn't it?
especially if they have that antiphospholipid antibody or a higher risk for clots during the pregnancy. Mm-hmm.
And is antiphospholipid antibody more common in women with like lupus, and is it more common in women of color?
It is very common in women who have lupus, and most of the time, the population affected most by lupus is African American women or women of color. Mm-hmm.
And why do you think that is? How much of it do you think is environment, or do you think more of it's genetic, or could it be related in part to immune system and vitamin D? I'm just curious if you have any thoughts about that.
I haven't dig further. The only thing I know from reading is still an area of exploration. But it could be a factor of, I feel, because epigenetics is a big thing, so it could be environmental stress related, because there's a lot of research coming on how stress can impact the telomeres of the DNA, so it could be related to epigenetics.
Actually, I did one of my podcasts on anxiety and why anxiety ages women, because it does shorten the telomeres. And so certainly we do have women in our practices, and women in general are more predisposed to autoimmune conditions than men. And for women with lupus, if they have active clotting, we don't usually use hormonal contraception or oral hormone therapy. But if they're stable without clots or active renal disease, we generally treat them just like we would any other woman. We wouldn't necessarily withhold medication or hormone therapy or other interventions from them.
And that was even brought up by, it was a researcher, medical researcher, who was she was vascular, I believe it was, I don't want to say I think it was a lady, Martinelli. She did a study on women who were at higher risk or had recurrent thrombosis and were on hormonal therapy and an anticoagulant. And what she found is there was no difference between the women who were not on any kind of anticoagulant or had any clot history of clot to those women who did have the recurrent thrombosis and on anticoagulant and on hormonal therapy. So she did a good study that was back in 2016 that was looking at women who are higher risk for clots and on anticoagulant and hormonal therapy.
Now, some of the unique situations why women might be more predisposed to having clots include pregnancy. And can you talk a little bit about pregnancy and why does that put women at so much more risk of clot when they're pregnant and even in the immediate postpartum time frame?
And that increased risk has to do with having lots of estrogen, very high levels of estrogen in the blood. And again, anytime that estrogen is in the blood, it has a way of causing that liver to synthesize more factors that cause the blood to be sticky. Plus, sometimes estrogen can lead to an inflammatory cascade, which can lead to more chances for clots to form. So that's where that risk comes for both pregnancy and postpartum, because it takes a couple of months for your hormones to settle out.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
And also just having that big belly and the baby pressing on the vena cava. Sometimes women can get varicose veins, which are a big problem. Are varicose veins a contraindication to using menopausal hormones?
Not that I've read or came across.
Yeah, I just usually recommend that women try to avoid prolonged standing, weight gain, and wear really good support hose. And there are increasingly some ultrasound and venous ablation techniques that can be done, at least for some of the superficial veins. But it's the deep veins, not just in the calf, but up the thigh, in the pelvis. Some women can get varices, pelvic varices, pelvic congestion syndrome, and have a higher risk of clot in the pelvis. And if it's in the vein system and it breaks off into the lung, you can have what's called a pulmonary embolus and die. Do you want to talk about the rare condition of central cerebral venous thrombosis, which can be quite devastating in younger women?
I have read about it, have not came across it as much.
Yeah, it's rare, thank goodness, because it can be quite devastating, and certainly dehydration can precipitate it. I know they took off the J&J COVID vaccine early on because they were noticing some increased cases of that in younger women. I just wondered if you had any thoughts as to why it seems like women are more predisposed. Is it just because they have estrogen, they're on birth control pills? Is it something else maybe about being female?
If I had to put a educated guess to it, I would think that it would probably have to do with being female, just like with your gallbladder, because being female puts you at increased risk because of for some reason, you get the slowing down of the gastric motility. I'm wondering if that would be the same process in the veins of the eye. But I have not really looked or thought to research behind that part. So you sparked my interest there.
So, if people have a family history of blood clot, do you do any special evaluations on the person if they themselves have not had a blood clot? Do you do like any hypercoagulable profiles, or what do you do in those situations?
If it's one of those factors like protein C or protein S deficiency, factor 5 Leiden, anti-thrombin or anti-phospholipids antibody, those would be more concerning for me to work up, because that would mean the patient in front of me, even though they haven't developed a clot yet, they are at increased risk. And my job, being a good primary care provider, is to do prevention. So I would try to figure out how can we prevent them from developing a clot.
And what are some of the other conditions that put people at risk for clot? Like, would you have any special travel recommendations? Do different types of surgeries, matter?
So as far as travel, let's start there. Any trip where you're going to be traveling more than 3 to 4 hours can put you at increased risk for clots, especially if you're not moving about. So the most common recommendation is, if you're driving, to try to take a break, gas break, or some type of stopping and resting. I feel like every 2 hours or so, or as long as you're not approaching that 3 hour mark. Same thing with
Yeah, I say the same thing.
And
Yep.
the same thing with airplanes. If you're taking a flight greater than 3 to 4 hours, there's different exercises you can find on the web that you can do while you're sitting in your seat. They do recommend you even try to get up, especially if you're at increased risk for the clots. That's the travel piece. For as surgery, with surgery, it all has to do with mobilization, and usually after surgery, you can't move about as much because you're in a little bit of pain, or trying to get your pain level down to move about. The most surgeries that are at risk are those invasive surgeries, which includes abdominal surgery, any type of chest surgery, pelvic surgeries, because you're usually having a longer time to recover.
And what about smoking? Does smoking affect whether you would give a woman menopausal hormone therapy? I know certainly it would in older women for birth control.
It's not as much as a problem in menopausal hormonal therapy because we're using such low doses. But in that case, if you're trying to minimize risk, the transdermal option would be the way to go there, especially for women at higher risk with a family history.
And what other kind of pearls of wisdom do you have for women in terms of them thinking about their long-term health, their loved ones' risk for blood clot, their own risk for blood clot, and just what can they do to be proactive?
The biggest thing is lifestyle. Lifestyle is about 90% of what can improve chronic disease management. So
Uh-huh.
I would
Uh-huh.
recommend being as mobile as you can. If it's on not on if it's just 10 minutes a day, that's a start, and you can always
Mhm.
push past that once you feel ready. Making sure that you're
Mhm.
eating well, because that also can impact those factors such as diabetes, hypercholesterol, um, that you'll want to work on to minimize your risk for clots. Um, you'll also want to make sure that you're keeping your stress down, that you're thinking about sleep, because all of those are inflammatory states, or can promote inflammatory states, and so that can increase your risk for clots. Knowing your family history, because there's a lot of patients that don't dig don't dig as much in their family history, and there's some things that are important if we're thinking about prevention. Knowing your medications and the risk, knowing the procedures that you're going to have done, and asking questions to inquire about recovery and how to minimize your risk for clots if it's a procedure that has a higher risk. Not being afraid to ask
Mhm.
questions and advocate for yourself, and if you need to, doing a little research.
Mhm. Yeah, so you can be very nice and pleasant and soft spoken like you are, Dr. Cochran, and still assert yourself and look out for yourself because that's so important. And I think the quote that you ended this chapter in is we must empower the voices of all women to be heard within the healthcare system. And I think that's so important. And anyone with a loved one in the hospital or a nursing home, they're at risk if they're not up and moving or if they're dehydrated, not able to, move their legs for whatever reason or having major lower extremity orthopedic surgery. Do you recommend aspirin or vitamin E for higher risk people for prevention, or do you just go straight to a standard anticoagulant if you think the person's at risk enough, or if they're intermediate risk? Do you ever recommend those things?
I feel yes, I have, because aspirin most people are coming. Most patients are familiar with aspirin in cardiovascular risk reduction because we use it a lot to lower your risk for heart attack and strokes. Those are clots as well, just in the arteries instead of the veins. So we do recommend aspirin, especially for patients at risk, more at risk for cardiovascular disease. It's no longer kind of a primary prevention unless there's certain risk factors present, like you have smoking, alcohol use, high cholesterol numbers,
Mm-hmm.
diabetes. Then your doctor may recommend the
Mm-hmm.
aspirin. Or if you have AFib, I have seen, or arrhythmias, I have seen some doctors use that if there wasn't a diagnosis of atrial fib, um, that's aspirin. And then as vitamin E, I myself haven't had to recommend it as much. I did it more in fellowship. Um, but there are some women, particularly the ladies with the MTHFR mutation, that like to be prevented, that like to prevent things that could be helpful for. But anytime you're doing any type of supplements over the counter, you just want to make sure your doctor is aware, just so that they can make sure that you're taking it at an appropriate dose. But yes, those can be very helpful besides going straight to an anticoagulant.
Because I've seen the vascular medicine doctors sometimes recommend that in people that they thought they had a provoked blood clot, but nothing genetic, and they're not really at risk. But aspirin I thought was better at reducing arterial clots and certainly can irritate the stomach. So I've seen some literature giving like 600 to 800 units of vitamin E. E is an Earl that can be helpful for reducing venous clots. But certainly people who take vitamin E and maybe they're taking ginkgo biloba, an herb, and they're getting older, they could actually be at risk for cerebral
Mhm.
hemorrhage. So it's a careful balance. It's such a delicate system, preventing bleeding and preventing clotting in the body. And it doesn't seem like much can happen to tip some people over one way or the other. And that can really, unfortunately have devastating consequences. And if you have someone who has an unprovoked blood clot, besides the family history and maybe checking them and doing a full hypercoagulable profile when they're off anticoagulants, because I see a lot of people treated in the hospital and then nobody follows up on the evaluation in the outpatient area. When do you start worrying that they might have underlying cancer? And that's the cause of their blood clots.
I feel like that comes from a good history of inquiring about the weight, because usually if there's a cancer, sometimes they having a decrease in appetite and they just put it off as something else besides cancer. I've seen that a couple of times. There can be certain red alarm signs, such as back pain, lower back pain, particularly at night. If they're having night sweats, particularly drenching night sweats with the weight loss or a decreased appetite. That's more lymphoma I'm thinking about. But usually you're going to be asked some questions. Even if you feel like you're fine, they should ask a few questions that should trick them, especially if someone's monitoring their weight, because the weight loss can be significant. And the patient may not notice it, but with that graph that we usually see when you see your doctor on a regular basis, we can see small changes that may make us work up something.
Yeah, all that is so helpful. We have been talking to specialized women's health expert and internist, Dr. Tiffany Cochran. If you want to read more about her or some of the information and great advice that she's given, she's on our speakingofwomenshealth.com site, and she's been a contributor. She's also published books in medical textbooks, Dr. Falcone's OBGYN surgical textbook. She wrote an excellent chapter on osteoporosis. And then you were one of the authors in Taking Care of You, the Empowered Women's Guide to Better Health. And I'm sure that's in people's local libraries and bookstores. Where can people contact you? Any websites or social media, or any other parting words that you would like to give our audience?
So I am working on being on social media. Right now, I don't have. I do have a. If you go on the Beaufort Jasper Hampton Comprehensive Health Services, or BJHCHS.org, they have a list of providers there that has my office information and the address of my clinic. I am on Instagram, but it's right now more of a fun page. I am working on
Personal.
I am working on trying to see if I can work in some health educational pieces on a separate page. So hopefully in the future that's something I can work on. And then,
Well, just be sure to let us know, and we'll update Speaking of Women's Health. And our executive producer, Lee Klekar, who I really appreciate so much, we can put your office website, if you want us to, in the show notes.
I will do that.
We can
I'll
do
send
that.
to you right after.
That's great. Well, you have been listening to the Speaking of Women's Health podcast. I am your host, Dr. Holly Thacker, and thanks for joining us for this edition of everything you want to know about blood clots in women. And if you don't already subscribe to our free podcast, anywhere you get podcasts, just hit the subscribe or click on the follow button. And please, if you can, give us a 5-star rating. And for free treatment guidebooks, you can go on speakingofwomenshealth.com, follow us on social media. And if you like to watch the podcast, you can go on our Speaking of Women's Health Rumble channel. And I'll look forward to seeing you back in the Sunflower House next time.